Welcome to Board Pearls. This is episode 3 of 5 of the Colonoscopy Practice and Quality chapter in the Endoscopic Procedures module. In this episode, we cover the malignant polyp and post-polypectomy surveillance, the anatomic rule that makes the muscularis mucosae the line that matters, the Kikuchi and Haggitt depth systems, the high-risk histologic features, including ITBCC tumor budding, and the USMSTF 2020 surveillance intervals. The last episode ended with the polyp coming off the wall. Now, the pathology comes back, and the single principle that resolves everything is anatomic. Submucosal invasion, not mucosal involvement, carries metastatic potential. Lymphatic vessels in the colon begin at the muscularis mucosae interface. Any neoplastic cell confined above this layer cannot enter lymph and cannot metastasize. That is the whole rule, and it explains the language confusion completely. Intramucosal adenocarcinoma is a pathologic descriptor used when dysplastic glandular elements involve the lamina propria but do not breach the muscularis mucosae. The word adenocarcinoma is misleading. In the colon, intramucosal adenocarcinoma behaves clinically as high-grade dysplasia because the lymphatics have not been reached. Complete endoscopic resection is curative. Surgery is unnecessary morbidity. The pull toward surgical referral comes from the word on the path report, not from the biology of the lesion. True colorectal cancer requires submucosal invasion, T1 or beyond, where lymphatics begin and nodal metastasis becomes possible. Once you are below the muscularis mucosae, the question becomes how deep and how dangerous. Two anatomic systems describe depth of invasion, one for sessile lesions and one for pedunculated. The Kikuchi system applies to sessile lesions and divides the submucosa into thirds. Kikuchi SM1 is the superficial third under 1,000 microns from the muscularis mucosae. Kikuchi SM2 is the middle third. Kikuchi SM3 is the deep third, over 1,000 microns or invading the deepest layer of submucosa. The Haggitt system applies to pedunculated polyps. Haggitt level 1 invades the head, Haggitt level 2 invades the neck. Haggitt level 3 invades the stalk. Haggitt level 4 invades the submucosa of the bowel wall below the stalk. Haggitt level 4 is roughly equivalent to deep submucosal invasion in risk terms, because the tumor has left the polyp and entered the wall. Historically, deep submucosal invasion alone was an automatic indication for surgical resection. That meant Kikuchi SM3, or Haggitt level 4, or invasion over 1,000 microns. The assumption was that lymph node metastasis risk was high enough to justify removing the bowel segment and its regional nodes. The contemporary cohort data reframed that binary cutoff. Deep submucosal invasion alone, without other adverse histologic features, carries only about 2.5% lymph node metastasis risk. That number is small enough to change the calculation in poor surgical candidates, where operative morbidity exceeds the absolute risk of leaving residual nodal disease. The modern approach is to aggregate histologic risk factors rather than treat invasion depth as a binary trigger. 4 high-risk features drive surgical referral. Poor differentiation, meaning grade 3 or higher, correlates with aggressive biology and higher metastatic potential. Lymphovascular invasion is direct evidence that tumor cells have already entered the lymphatic or vascular compartment. Tumor budding is the count of single tumor cells or small clusters at the invasive front. And a positive resection margin, under 1 millimeter of clear tissue between tumor and cut edge, means residual disease cannot be ruled out. Tumor budding deserves its own moment because the definition is precise and exam-testable. By the International Tumor Budding Consensus Conference, a tumor bud is a single tumor cell or a cluster of up to 4 tumor cells at the invasive front. The count is performed in one hotspot of 0.785 square millimeters. High-grade budding, 10 or more buds in that hotspot, is associated with substantially higher lymph node metastasis risk and pushes the decision toward surgery. The mechanism behind tumor budding is that detached or loosely cohesive tumor cells at the invasive edge reflect epithelial mesenchymal transition and the early steps of metastasis. So when any of the 4 high-risk features is present, surgery is strongly indicated regardless of submucosal invasion depth. When none is present, deep invasion alone may not warrant surgery, particularly in poor candidates, and en bloc resection at the time of polypectomy is essential. because piecemeal removal makes accurate assessment of any of these features impossible. Now, surveillance. Because once the polyp is out, the question is when the patient comes back. The 2020 U.S. Multi-Society Task Force update on follow-up after colonoscopy and polypectomy drives interval selection from index findings. The principle underneath the intervals is straightforward. The likelihood of metachronous advanced neoplasia within the surveillance window is calibrated to the highest risk lesion at the index exam. The intervals step down as risk steps up. A normal colonoscopy, or up to 20 small hyperplastic polyps under 10 millimeters in the rectosigmoid, only returns to a 10-year interval. Metachronous risk in these patients is at population baseline. 1 to 2 small tubular adenomas under 10 millimeters with low-grade dysplasia gets 7 to 10 years. 3 to 4 small tubular adenomas gets 3 to 5 years. The 3-year interval is the default short interval, and it applies whenever any single high-risk feature is present at the index exam. The features are 5 to 10 adenomas, an adenoma 10 millimeters or larger, tubulovillous or villous histology, or high-grade dysplasia. On the serrated side, a sessile serrated lesion 10 millimeters or larger, a sessile serrated lesion with cytologic dysplasia, or a traditional serrated adenoma. Any one of those features triggers 3 years. More than 10 adenomas at the index exam triggers a 1-year follow-up and should also prompt evaluation for hereditary syndrome, because that polyp burden is outside what sporadic biology produces. The serrated side mirrors the adenomatous side at the lower risk end. 1 to 2 sessile serrated lesions under 10 millimeters gets 5 to 10 years. 3 to 4 sessile serrated lesions under 10 millimeters gets 3 to 5 years. A proximal hyperplastic polyp 10 millimeters or larger is treated as a sessile serrated lesion for surveillance at 3 years. The reason is pathology inter-observer variability between hyperplastic polyps and sessile serrated lesions at this size and location. Large proximal hyperplastic-looking polyps are probably misclassified sessile serrated lesions. The surveillance interval should reflect the higher risk lesion the pathology may be missing. When multiple findings drive different intervals at the same colonoscopy, the shortest interval applies. The reason is the same principle that organizes the whole table. The highest risk lesion is what governs metachronous risk for that patient. A patient with both 2 small adenomas and a 15 millimeter sessile serrated lesion does not get the 7 to 10 year interval for the small adenomas. They get the 3-year interval for the larger sessile serrated lesion because the larger lesion is what predicts what will happen in the colon over the next several years. Piecemeal EMR of any lesion 20 millimeters or larger triggers a different surveillance pattern that does not fit the metachronous framework. Site surveillance at 6 months, then 1 year, then resumption of standard intervals. The 6-month interval is not a scheduled surveillance interval. It is a site check designed to detect and treat residual or recurrent adenomatous tissue at the EMR scar before it grows into an interval cancer. Local recurrence rates after piecemeal EMR of large lesions are about 15 to 20% without adjunctive techniques, falling to 5 to 10% with snare tip soft coagulation of the margin. 6 months catches recurrence early, when it is still amenable to repeat endoscopic resection. 1 year confirms durability of the site. Then the patient rejoins the standard interval schedule based on what was found at the index exam. Pull the malignant polyp and surveillance half together. The malignant polyp turns on one anatomic fact. Lymphatics begin at the muscularis mucosae, so intramucosal disease is cured by resection, while submucosal invasion opens the door to nodal spread. The modern algorithm aggregates depth with tumor budding, differentiation, lymphovascular invasion, and margin status rather than acting on depth alone, which is why en-bloc resection matters for the histologic read. Surveillance then calibrates the next exam to the worst lesion you found, with shorter intervals for higher risk findings, the shortest interval winning when findings conflict, and a separate 6-month site check for piecemeal EMR of lesions 20 millimeters or larger. The teaching is recognition driving technique, driving timing. The next episode picks up where the polyp comes off the wall and goes wrong. The post-polypectomy adverse events, delayed bleeding, and post-polypectomy electrocoagulation syndrome, and how each traces to the thermal injury the technique choice already predicted. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 5 of chapter 30, and I'll see you in the next one.